thank you very much for being here, and thank you very much for listening to this talk. I think I will completely change what we were discussing about omics. I'm here going back to basics also in terms of no digital technologies being discussed here. But I think there are some really interesting points connected that we were talking about patient-centered, one-size-fits-all, and precision medicine. So when I was first invited to give this talk, I got a different title, and it made me think of two questions. The first one is, when do we talk with the patients? When do we start listening to the people's voice? Do we have to wait until a clinical diagnosis and to avoid the worsening of a condition, or can we start listening to patients before, to people before they have a condition, when we talk about secondary prevention, when we already have some signs, or even before, when we think about risk factors? And the second question, which I think it's more important, is why? Why do we want to listen to the participant's voice? Why do we want to listen to patients? And I thought of three answers that I think are here. First, because we might be asking the wrong questions. We might be creating questionnaires where we are not asking what is truly important for participants. Second, because we might not be measuring what is important. And here's something that we learned from Mobilise-D. For instance, in COPD, we ask participants to walk during 6 minutes to assess how many meters are they able to walk, to see what's their ability to walk in a flat corridor in the hospital, but we don't know what happens outside. And when we talk to them, what they say, it's very different when you walk on a flat corridor in the hospital than when you're at home in an uneven surface, when you have your grocery bags, when you have to manage what happens in the environment outside of a hospital. And finally, because we might be proposing incorrect interventions. We might be creating great studies on how good is cross-country skiing in terms of mobility for older adults, but this is something that we cannot apply in Barcelona, where it never snows, or in a country like mine in Colombia, where we don't even have seasons. So basically, the message is, good intentions are good, but they're not enough to make an impact. And what we often hear from patients is, nothing for us without us. So with that little background, I'm going to talk about what we have learned in Mobilise-D and what we have been doing in Mobilise-D. OK, so this is what we have learned in Mobilise-D so far. First thing is, we know walking is crucial, and walking is crucial for an active and healthy aging. However, it's something that changes with age and in the presence of chronic conditions, as we tend to slow down, and it requires a higher physical exertion. This is why the research on how to assess and modify walking is so important, and that's why it has become a global priority, and we have projects like Mobilise, where we are assessing it. But however, for this research to be impactful, we have to go back and understand which are the aspects of walking that are truly meaningful to individuals, especially to those living with walking impairment. And this is why we ended up with this very simple yet complex research question. How do people living with chronic conditions experience walking? And it seems very simple, but once we start dissecting the question, it became harder and harder to explore. So we have to decide, how are we going to talk about them? So it was really easy to notice that it was unfeasible to look at all chronic conditions. And as we saw before, we could have pediatric patients, we have younger adults, older adults, and we need to address. So we focused exclusively on adults living with highly prevalent geriatric, cardiopulmonary, and neurological conditions, namely Parkinson's disease, multiple sclerosis, chronic obstructive pulmonary disease, COPD, chronic heart failure, hip fracture, frailty, and sarcopenia. And we wanted to understand what was about walking. But it was not what happens walking in inpatients in a hospital. It was about walking outside. What happens in daily life, free living, unsupervised scenarios, so real-world walking. And for this, we follow a framework developed earlier by the Mobilise team on what we would consider is real-world walking. Finally, what we were interested was exclusively about experiences, perspective, preferences, and what patients had to say. And because that's what we were interested in, we focused on qualitative research. This was a work we did almost exclusively on qualitative research. And that's how we ended up with our main objective, which was to identify and synthesize evidence describing walking as experienced by individuals living with chronic conditions. And if results were good enough, we were going to be able to propose a conceptual framework. And the way we did it, well, we started with a systematic review of qualitative evidence, and then we follow a methodology called a meta-ethnography, that for those of you who are not experienced in qualitative research, it's similar to what a meta-analysis for quantitative research would be, but in terms of qualitative. What it has is that it was first developed in '88 by Noblit and Haar, and it's a qualitative research synthesis method that it's able to interpret reality. So it's based on the idea that actors interpret reality, and we as observers are able to interpret those interpretations of reality. So it becomes very interpretative, but it's able to go one step beyond, and it's able to generate new theory from those interpretations. And it basically works like this. It has 7 different phases, from which the first 2 are very close to what we do in a systematic review. So we establish an important research question, a protocol, a strategy. We go into the electronic databases. We extract those data that we consider interesting, and we start the interpretations. And we start with the qualitative synthesis, where we start to identify what are the key metaphors and the key ideas from the individual studies, and we start to see if we can translate one into the other. And finally, we synthesize everything, and as I'm going to show you. So basically, what we did in the first part of the systematic review, we stopped and looked at, once we had the eligible studies, we wanted to understand where they come from, what were the population characteristics, what was the setting, the main topic that was being addressed, and what was the analysis. We wanted to understand if those results that we have were coming all from Europe, or if we were seeing diverse populations. We wanted to understand if it was only about severe patients, or if we were looking at all kinds of patients, and if we had one condition that was biasing our results, or if we were seeing things across different conditions. Then we wanted to know what was the quality of those studies, and how closely related were those studies to our research question. And then it became the part of the interpretation, and I just put these arrows here to show you this is not a linear process. It took us months and months of interpretations and months of meetings to try to understand what we were collecting from participants, what we were collecting from previous researchers, and if it all made sense together. And this is what we found. So after looking at more than 2,500 papers, we ended up including 117 studies of qualitative research looking at how people living with chronic conditions experience walking. And from those 117 patients, as you can see here, we had most of the conditions that we were looking at, except for sarcopenia. So what we found is that across 6 different conditions, we noticed that we found 7 interrelated themes that all explain the experience of walking as lived by people living with diverse chronic conditions. So the first topic, we call it becoming aware of the personal walking experience. And what we notice here is that in the presence of mobility impaired conditions, the walking deteriorates and it begins to require a conscious effort that results in an awareness of walking. So we notice that the walking changes. It's no longer something that we take for granted, and it requires a conscious effort and a higher physical exertion. And we start comparing the walking from now with the walking from an effortless past when it didn't used to happen. So here we would have quotes like this one. So I'm always aware of the distance, of how far I have to walk. I'm always aware of the temperature. It's like a second nature to plan ahead. Or I feel like walking is a conscious effort now and it makes it stressful. And here, the effortless path. No, we used to go for long walks, but now we cannot do that. Then the second thing that we found was that the walking experience is a link between the activities and the sense of self. So walking usually in individuals relate to the ability to perform activities of daily living. And those activities of daily living can be as basic as going to the bathroom in the morning or dressing up. They can be instrumental, such as going grocery shopping or preparing food at home. They can be leisurely, when you walk your dog, or when you go out with friends for a walk, or they can be work-related, because we think about people that are still in working age, and also transportation and community. But when walking impairment is affecting our ability to perform those activities, it can have an impact on the social roles and in the identity of individuals. So individuals start discussing the threat to their own identity, and they start talking about how their independence, their control, it's being threatened by the walking impairment. And here we would have this kind of quotes. No? All participants had experience of feeling helpless related to a sense of their own identity being put under pressure. No? To feel mobile, especially to be able to move without needing help from others. I guess this is the feeling of being independent that I find so important. So we have becoming aware, the connection with the activities of daily living and the identity, and then what we were expecting at the beginning with our research question, which is the physical walking experience. And it's this idea that individuals living with mobility impairing conditions experience an overall sense of loss of their physical function. And what made harder a little bit the way of identifying one unique way of feeling this loss of physical function is that we find individuals talking about how far they are able to walk now compared to the past, how fast, or for how long. So we have different expressions of the loss of physical function. We had conditions where we expected this variability and unpredictability, changes between one day to the other, 1 hour to the other. But we also found it in conditions where we were not expecting those changes. There is an overall progression towards walking impairment, but still there is some variability connected to the medication. And some changes in the walking performance, how much they are actually able to do in real-world scenarios. And finally, the signs and symptoms that could be common across conditions such as weakness, balance, weakness, lack of balance, or fatigue, or pain, or disease-specific. So here, for instance, we would have a big problem is with hypokinesia. The most frustrating is not always being able to walk. Suddenly, you stop and your legs won't move. So we would have disease-specific symptoms, but we would also have bigger ones. Then we found that it was not only about a physical experience, it's also an emotional and mental one. And there is a complex element associated with the loss of physical function, which is connected to the mourning and feelings of loss that trigger feelings of fear, anxiety, embarrassment, loneliness, or stress. But here in the balance, we also found some positive feelings. When you lose your ability to walk, or when your walking is impaired, there's also a sense of motivation, achievement, of satisfaction when you are able to do things, when you can go back, or after training, after pulmonary rehabilitation, for instance. So here are 2 examples. The anxiety was reported to increase symptoms of Parkinson's disease, resulting in walking difficulties such as shortened step length and increased shuffling or dragging leg, feeling hurried, examined, stigmatized, or judged. No? And then the achievement example you can see here. But walking was not only physical and emotion, it was also a social walking experience. And here we can see that the social experience can be hindered or enhanced by walking impairment. Here it's about how important are your social connections, your support, what happens with the family, the friends, the community, the health care professionals. There's feelings of belonging and otherness. I'm part of the community, I can still be with my friends, or there's a feeling of otherness, I can no longer do the things with my friends, I feel isolated at home. So here are some examples. We can look at them later because of time, but okay. I also think that support from my family, your partner, husband or wife, is pretty important on day-to-day routine. Yeah? And then to participate in social activities within or outside the family. The 6th is the context. So walking is related to activities we want to perform, and it's connected to the context. Where are we walking? We're walking in the physical space, so we're walking at home, outside of home, in the community. But there's also a context associated with the values, with the social and cultural context of this individual where the walking is impaired. And a personal context connected, for instance, with aging, with comorbidities that we can see here. And our final theme was this. It's called Behavioral and Attitudinal Adaptations Resulting from the Walking Experience. And it's the idea that once walking changes, it becomes a dynamic process where we have to cope with change. And we have to adjust not only the behavior, but the attitude of individuals. So we will have to find ways to maintain function, such as the use of walking aids or the change between one walking aid and another one. Ways of managing with this changing ability. So we need to learn, prioritize, plan ahead, change, like forego some activities that we can no longer perform, and adjust the attitude accordingly. So here you can see some examples, no? You have to constantly think ahead, plan a little bit more your activities in relation to your medication in the case of Parkinson's disease. So just to put, we found these 7 themes. We wanted to see if those 7 themes arising from the literature and arising from our interpretations made sense. And we have the support from the Mobilise-D patient and public advisory group. We met with them. We actually met with patients living with those conditions. We presented what we found, and we discussed with them if it made sense. And that's what we call the face validity part. And then, as co-authors, we also have some clinical experts, people working in this geriatric, cardiopulmonary, and neurological conditions that could tell us if this made sense also for healthcare professionals and researchers. And that's how we ended up with the framework that I hope you have seen before and you keep seeing, where you can see here, now we have walking experience is multifaceted. There's a constant interplay between the physical, the emotional, and the social components that we saw before. The walking experience is framed within a context, and it's connected to the activities that individuals want to perform on the daily living. And the walking experience creates a connection between those activities of daily living and the sense of self, the identity of individual, as changing abilities shape the social role, attitudes, and behavior over time. As we saw, well, we did the publication, but as part of the meta-ethnographic work, we have to go beyond a scientific publication because we're talking about the patient's experience, and we have to go beyond that. And that's some of the activities we have been doing to spread the word to the general public and to discuss it with even more people living with chronic conditions. And some take-home messages from the participants, no, from patients. So what we learned that walking is truly a complex and meaningful aspect of health for people living with diverse health conditions. We learned that it's multifaceted. It's not only about a physical experience. We learned that it's dynamic. It's changing and constantly being changed by what's happening in the individual's context. And it's universal. We found commonalities across 6 conditions that we did not find that were going to be there. So our framework is grounded in the needs and lived experiences of individuals, and we hope it provides a novel theoretical framework structure for patient-centered clinical practice, research, and public health. And now I do this one.